Historically, FCR is the standard chemotherapy regimen for young fit patients with CLL. So a few years ago, as new drugs such as Ibrutinib and venetoclax were being developed, we started thinking that how do we identify patients which then benefit the most for a regimen such as chemoimmunotherapy, such as FCR. And in that, we figured that patients who are mutated for IGVH, they derive the most long-term benefit. Patients who have deletion 17p, chemotherapy actually does not work for those patients. So we designed a clinical trial where we just included patients who are mutated for IGVH without deletion 17p. At the same time, we realized that the FCR is traditionally 6 cycles, but we felt that 6 cycles of chemotherapy can be myelotoxic and can potentially lead to therapy-related MDS and AML long-term risk. So we wanted to cut back on the chemotherapy, incorporate the novel agents such as Ibrutinib, because we knew that Ibrutinib can lead to more MRD negative remissions when combined with chemotherapy. At the same time, Obinutuzumab, which has been shown to be superior to rituximab in the CLL11 trial, in terms of overall survival now and also MRD negative remissions. So we felt that we could modify the FCR regimen to create this new regimen, which we call iFCG, which is Ibrutinib, Fludarabine, Cyclophosphamide, and G stands for J101, which was the original name for Obinutuzumab. And how we give this regimen is that the chemotherapy is given for 3 cycles only, and after that patients get, depending on the MRD status, 3 or 9 additional months of Obinutuzumab. All patients get 9 additional months of Ibrutinib, and at that 1 year, if they are MRD negative, patients stop Ibrutinib as well. So they stop all therapy and we monitor them. So this regimen now we have been using at MD Anderson for our patients for the last 2 years. At the ASH meeting last year, we had reported the results, and the early results of the trial shows that at 3 years after receiving the chemoimmunotherapy, this iFCG regimen, almost close to 90% of the patients were MRD negative in the bone marrow. And when we look at our historical data with the FCR, if the same patient population received 3 cycles of FCR, our MRD negativity rate in the bone marrow was 26%. So we believe that this is a substantial improvement in the patients, in the response of the patients after receiving 3 cycles of chemoimmunotherapy. So that's the regimen we are pursuing as a standard regimen now for our young patients with mutated IGVH.